started. Good afternoon, everybody, or good evening if you're in the eastern part of the country. This is a webinar on the posterior pituitary hormones, AVP and Oxytocin. A couple people still aren't muted. Pamela, you got to mute.
Oh.
Okay, that's better. We're going to be talking about the posterior pituitary. The posterior pituitary gets its innervation in the neurohormones from the hypothalamus, specifically the parvocellular nucleus of the hypothalamus, which is over here. And it has a couple components. It makes both vasopressin, which is also called ADH or Arginine Vasopressin, AVP, and also the hormone oxytocin here. These go down and then some of it, especially oxytocin, also comes from the supraoptic nuclei. It goes down the hypothalamic posterior pituitary stalk down here until it gets to the posterior pituitary. It again gets released in the posterior pituitary and goes out of the venous outflow of the pituitary while the blood goes into this posterior pituitary over here, and that's how the hormones are released. So any damage to the posterior pituitary, the stalk, or the hypothalamus over here has the potential to give defects in oxytocin and vasopressin. And you can see another view here. The hormones go down from the hypothalamus. They're into these hypophyseal portal veins over here. Goes to the posterior part of the pituitary over here. And there's these venous plexuses here. The hormones go out both the anterior pituitary over here and the posterior pituitary over here to the bloodstream. Now, I think it's most interesting that we do measure most pituitary hormones. The exceptions are we rarely measure AVP. We usually don't measure oxytocin. We don't measure beta endorphin. We measure prolactin if it's high, but not particularly if it's low. And we don't measure the MSHs. They're alpha MSH, beta MSH, and gamma MSH. All of them we usually don't measure and we usually don't replace. And I want to bring up the issue. Maybe we should be looking at and replacing some of these hormones, specifically today the top two. So you can see here again the posterior pituitary releases ADH, and I'll talk more about this in a second. It mainly goes to the kidney tubules. The oxytocin, at least traditionally, has been thought to go to the mammary glands, involved in milk production, and the uterine muscles involved in labor and delivery. Now, first of all, oxytocin, vasopressin has a lot of actions. I found this nice little slide here. It seems to control almost everything. It has effects on the bone, pain, metabolic syndrome, diabetes, lipids, hypertension, chronic kidney disease, aging, social behavior, cognition, cellular proliferation, inflammation, infection, homeostasis, hypothalamic pituitary adrenal axis, and pain. So you would think if it does so many things, we want to be measuring this all the time, and we want to be looking for some of these defects and these symptoms here related to AVP deficiency. And this is another slide showing similar here that there's different receptors. I'll show that on the next slide. The V1 receptor is in the brain. It therefore is involved in things like anxiety and stress. This is something that's called the V1B receptor. And also, the V1B receptor is also called the V3 receptor, where it's in the anterior pituitary and controls ACTH release. So the V1 is involved in anxiety and stress in the brain. The V3 receptor is in the anterior pituitary that's involved in ACTH release. In the heart muscle, it's involved in muscular hypertrophy at the V1 receptor. In the blood, it's involved in platelet aggregation, van Willebrand factor release, which is involved in clotting. It's involved in gluconeogenesis via the V1 receptor in the liver. It constricts blood vessels. It's one of the most powerful blood vessel constrictors, and that's why it's called vasopressin, because it raises your blood pressure by constricting your blood vessels. And its most important aspect is through the V2 receptor at the kidneys involved in water retention here. And this shows the brain hypothalamic pituitary adrenal axis. And the important issues is the brain has cytokines, growth factors that regulate CRH, corticotropin releasing hormone, we know about as the hypothalamic hormone, but also the AVP coming from hypothalamus via the posterior pituitary. Both of them regulate ACTH. The CRH is a little bit more important, but the AVP is crucial also. These go from the pituitary of the ACTH goes down to the adrenals to make cortisol. So AVP is very important in cortisol regulation in addition to its cousin CRH. Now this shows the vasopressin receptors, and again, this one is called the V1A, sometimes it's called the V3. It's involved in it's present on vascular smooth muscle, platelets, hepatocytes, and myometrium. It's involved in vasoconstriction, cardiac hypertrophy, platelet aggregation, glycogenolysis, and uterine contraction here. The V1B receptor is involved in ACTH, prolactin, and endorphin release, and is present on the anterior pituitary gland. The V2 receptor mediates through cyclic AMP and is involved in the basal membrane of the collecting duct of the kidneys. That's what CD stands for, the collecting duct. It's also involved in the vascular endothelium and vascular smooth muscle cells. It has to do with the aquaporins, water channels, and is involved in releasing of the von Willebrand factor and factor VIII, which has to do with clotting, and also is involved in vasodilatation. Now this slide here shows the relationship between plasma AVP and plasma osmolality, so under normal state. So in general, when the plasma osmolality is in the normal range here, normal range is below, say, 280, the plasma AVP is usually pretty low here. As you get dehydrated and you get thirstier, your plasma osmolality increases, and what happens, it kicks in AVP. So the AVP starts rising. So as you get a water defect, your plasma osmolality increases, and as it gets above 290, plasma AVP starts rising, and you get renal water excretion. You get rid of your, you decrease your renal water excretion. You hold on to water, and this would lower the plasma osmolality down. You're holding on, you're bringing back water, you're urinating less, and your plasma osmolality normalizes. On the other hand, when you have water excess, your plasma osmolality decreases, your AVP goes down low here, your renal water excretion increases, you get rid of free water, and your plasma osmolality tries to maintain this range of about 280 to 295 or so. But at some stage, if you assume your pituitary is not working, or your posterior pituitary is not working, you're not releasing AVP, that you can have a rise in the plasma osmolality, and the AVP doesn't kick in and doesn't get released. And that is a condition called diabetes insipidus. And I love this slide here. Thank goodness we have ADH. You're in the desert. You want to conserve your water. You don't want to urinate your water. You want to conserve it so your plasma osmolality doesn't go up. So diabetes insipidus is a condition of AVP or ADH, if you want to call it that, deficiency. The symptoms are usually excessive urination and thirst, especially you urinate at night. And the mild cases are probably common, and I think we probably undertreat this. This can happen with any defect in the hypothalamus, the stalk, and the posterior pituitary, prior surgeries or infiltrations. And you can get these conditions of AVP deficiency. And the reason why it's very important to treat it is if you have excess urine, it can lead to bladder distension and kidney problems, and can be chronically bad for you. So this is not only inconvenient, you have to wake up and go to the bathroom a lot, you also can have damage to your bladder and your kidneys. And I think the crucial question I ask my patients is, how many times are you waking at night? So if you're waking up 4 times a night and you had prior pituitary surgery, you definitely have a good odds of having this diabetes insipidus. So what I do is I have the patient first collect the urine for 24 hours, and I measure the volume. A volume greater than 3 liters indicates diabetes insipidus is possible. And then I confirm by having them do a 12-hour fast with no water. Usually have them stop eating and drinking at 8 o'clock at night, and in the morning at 8 a.m. I get a serum and urine osmolality, as well as an AVP level here. Diabetes insipidus is marked by a high serum osmolality, usually greater than 300. A low urine osmolality means that they don't concentrate the urine. They have dilute urine in spite of having a high serum osmolality. They usually use the cutoff about 500. And also they have a low AVP level of less than 1. I'd like to see all 3 of these when I make the diagnosis, but I think the low osmolality is the most important one. People used to do what's called a formal water deprivation test, where they kept the people without water for like 16 hours. It really didn't matter that much difference between 12 hours and 16 hours, so people don't do this formal water deprivation test anymore. It's usually the 12-hour fast is suffice. However, I think this test is really looking at the effects of vasopressin deficiency on the diabetes insipidus, on the effect on the collecting ducts and the water retention. And somebody can have vasopressin deficiency with other symptoms. We talked about the different receptors, and can have other symptoms of vasopressin deficiency besides the diabetes insipidus that may manifest for the patient and not show up on this water deprivation test. So what do you do if you fail with the water deprivation test and have diabetes insipidus? I usually give pills. The pills are usually the best. Several endocrinologists recommend the puffs, but I don't think the puffs are as consistent. The advantage of the puffs is they work very quickly. The pills take a little bit of time, so some patients that feel like they start urinating right away, the puffs are good, but other patients, the pills are much more convenient and more consistent. I have the patient take most of their dose at night to prevent waking up at night. Nobody likes to wake up 3 or 4 times at night. And they can, although sometimes you don't have to, take a second dose in the morning. I like to have a period of breakthrough urination where they're urinating, a fair amount that's making up for them not urinating overnight. So they should have some excess urination. The treatment is pretty benign. It is important to follow their sodium level. If they're on too much DDAVP, their sodium's often low. If they're on too little, it's high. So I would usually get a sodium level about every 2 or 3 months or so. Okay, and now we're going to switch to oxytocin. This is on the Empower, EMPOW, capital HER.com website, where I have one article posted. It's a cool picture. Oxytocin is often called the love hormone, the social hormone, the cuddle hormone, and the happy hormone. There's a nice happy couple. Oxytocin is made by the posterior pituitary, like AVP, and I would say it's the only prominent pituitary hormone not tested or replaced. The other ones I think are less prominent, but oxytocin I think is sort of in that category that is becoming more important to test and replace it. Patients with more complete hypopituitarism are thought to be more likely to have oxytocin deficiency, especially those that have an AVP deficiency. AVP and oxytocin can be co-secreted. They often would go together, and it would be likely that if they have an AVP deficiency, they can also have an oxytocin deficiency. I don't think that's proven for sure. There might be some patients that have oxytocin deficiency and not AVP, and maybe the other way around. But I think in general, people think that they would go hand in hand. There was a 2015 abstract by Elizabeth Lawson showing that oxytocin gives weight loss in men. I think they started putting oxytocin on the map, and there's been a couple of interesting publications since then. Some of the symptoms and diseases related to oxytocin deficiency, and I want to stress that word related. This means that people can have some of these symptoms and, in theory, have a low oxytocin level. It doesn't show causality. We don't know for sure that these diseases lead to oxytocin or corrected by oxytocin treatment, but there's been some articles in the literature and certainly on some websites that oxytocin deficiency is related to these problems. These include menopausal or surgical menopause, prolonged stressful situations, hypothyroidism, depression, AIDS, CMV virus infection, multiple sclerosis, fibromyalgia, chronic opioid use, Parkinson's disease, Prader-Willi syndrome, feelings of loneliness, anxiety disorders, schizophrenia, and autism. So this is quite a list, and it will be very important as the years go by to see exactly how much oxytocin plays a role in some of these diseases and whether treatment with oxytocin helps improve these diseases. Some of the potential benefits of oxytocin include help with labor and delivery. I think that's clear. People do use oxytocin for women that are not progressing through labor. It's used quite effectively in that category. Oxytocin is involved in milk production. I don't think it's particularly used in this. There's other agents that also help with milk production, such as domperidone, which are more often used, but definitely this is a fairly clear role. The rest of them are a little bit more newer and more theoretical. There's a lot of talk about bonding, especially in females, but possibly in males. There's some animal experiments where you put a mother with her baby and oxytocin levels go up. Doesn't usually happen with the father, but occasionally it can. It seems to help control pain. It can help with intimacy, specifically being more open to intimacy, help with achieving orgasms, issues of trust, energy and confidence. It can often be thought to be improving abdominal pain and other symptoms of GI discomfort. It seems to prevent social withdrawal, and it stimulates stem cells in the bone marrow to create new bone. So all these are potentially important beneficial effects of oxytocin that need to be studied more. An interesting concept is about breast implants and oxytocin. Breast implants are concerning because they damage the connection between the nipples and the brain, and in theory can lead to decreased oxytocin synthesis. So I want to highlight a couple of recent papers in this past year. A paper by Phenol, there's this picture over here, came out in the International Journal of Obesity on oxytocin's inhibitory effect on food intake is stronger in obese than in normal weight men. This group gave oxytocin at 24 international units via the intranasal route to 18 young obese men as compared to 20 normal weight men. The oxytocin markedly reduced hunger-driven food intake in the fasted state in obese, but not in normal weight men. So it did seem to decrease their food when they're hungry, but just in obese men. Oxytocin led to a reduction in snack consumption in both groups, but it didn't affect energy expenditure. The hypothalamic pituitary axis secretion and the postprandial rise in blood glucose were blunted by oxytocin in both groups. So we'll talk about in a second the importance of oxytocin on cortisol production. It seems to be that's one of its clearer effects. And some of this could be beneficial and some of it could be detrimental. If you're taking cortisol, you may need more. If you are overweight, which is often a state of high cortisol, this may help decrease the cortisol. Elizabeth Lawson published in Obesity in 2015 that oxytocin reduces caloric intake in men. This was a randomized placebo-controlled crossover study of a single dose, one dose of oxytocin, 24 units, in fasting healthy men. Oxytocin reduced caloric intake with a preferential effect on fat intake and increased the levels of the anorexigenic hormone, which is a hormone that decreases your appetite. It didn't affect appetite itself, and it didn't affect appetite-regulated hormones. The oxytocin reduced the caloric intake by 122 calories per meal, which, if sustained, and I want to emphasize the word if, because in general, short-term weight loss doesn't necessarily lead to long-term weight loss, but if you cut down 122 calories per meal over a year, it would be a 17-kilogram weight loss per year, which is about 35 pounds. And here's a list, the figure from the paper showing total caloric intake went down with oxytocin. The amount of fat in grams that they chose to eat went down. The protein did not change significantly, and the carbohydrates did not change significantly. There's another recent paper out about oxytocin is beneficial to in young children with Prader-Willi syndrome. This was published in Clinical Endocrinology in 2016, very recently. Prader-Willi syndrome is known for hyperphagia, increased food intake, with impaired satiety and a specific behavioral phenotype with stubbornness, temper tantrums, manipulative and controlling behavior, and obsessive compulsive features. Prader-Willi syndrome is associated with hypothalamic and oxytocinergic dysfunction. So this group here from Coupens did a crossover intervention with twice daily intranasal oxytocin at a dose between 24 and 48 international units per day versus a placebo administration. Both were over a 4-week period, and they were in children, 25 children ages 6 to 14. In the total group, there was no significant effects of oxytocin on social behavior or hyperphagia. They didn't eat less, their social behavior didn't improve. However, in the 17 children younger than 11 years, a pretty small number, parents reported significantly less anger, sadness, conflicts, and food-related behavior, and improvement of social behavior during the oxytocin treatment compared with the placebo treatment. The conclusion was that intranasal oxytocin administration has beneficial effects on social behavior and food-related behavior in children with Prader-Willi syndrome younger than 11 years of age, but not in those older than 11 years of age. So it seems to be an age-dependent effect. And then in terms of the oxytocin interaction with hormones, there's very little published on this. However, there was a paper published in 1988 that oxytocin therapy decreased serum cortisol levels. It was actually, I looked at the paper, it decreased exercise-induced ACTH and cortisol rise. It didn't really affect basal cortisol, but it did affect ACTH and cortisol rise. And many of my patients that have been on oxytocin have reported that the cortisol requirements go up and they're more likely to get adrenal insufficiency. So I do think this is a real effect. Some of the beneficial effects on weight loss may be from lower cortisol. There was one study suggesting that oxytocin supports thyroid function by improving the import of iodine into thyroid cells. I don't think this is clinically important. I don't see the oxytocin deficiency patients being hypothyroid or getting better with oxytocin treatment. Most people get enough iodine into the thyroid cells, so I don't think it's that important, but it is an interesting finding here. In 2011, researchers published a paper in Menopause that topical oxytocin therapy could treat vaginal atrophy. So in terms of oxytocin supplementation, oxytocin is available from several compounding pharmacies as either sublingual tablets or nasal spray. And during the chat session, I'd like to get patients' opinion about nasal versus sublingual and where they get theirs from and how they like their supply. I did give a questionnaire for my hypopit patients to complete before and after oxytocin administration, and we haven't analyzed it that much, but there's a lot of defects in the patients before. I would like to see some more of what happens after the oxytocin and see if some of these symptoms improve. There is a laboratory called Meridian Valley Labs in Washington State that we've been measuring a 24-hour urine oxytocin level. It's commercially available. It is not usually billed to your insurance. I think it's $150, so it's not cheap. And the patients that have a level below 350, I've been putting on oxytocin. I'd like to see more. Does it go up after oxytocin administration? So some of the people that are on it, I think it would be worthwhile getting your labs checked again. The company did not give me any real information on reliability of the assay. I tried to get it from them. Unfortunately, they weren't that forthcoming from it. But please contact us if you're an established patient. If you want to be on oxytocin, I can send you the information and the instructions on the testing and the questionnaire. And if you're not one of my established patients, this might be a good thing for you to come. So I'm going to take a little break here, and we're going to open up to Eugenia and then to the floor here. So think about your questions for vasopressin and oxytocin. You can email us here to set an appointment, or if you have questions about the seminar today. I do have an article on oxytocin for patients with pituitary dysfunction on my website, and it was nice. I Googled oxytocin pituitary dysfunction, and my article was the first one to come up. So there's not too many people working on this, although I think there will be others shortly. I'll post the webinar in a few days on my website here. So I'm going to transfer this over to Eugenie, who's going to talk about her son a little bit, and then we're going to open up to everybody.
Hello.
Hi. Hi. Go ahead.
Can you hear me?
We can hear you.
Well, what would you like me to say?
Well, tell us what happened with your son's, what his symptoms were before, what happened on the different doses of oxytocin, and you think it's worthwhile, and just give us your thoughts about it, since I think you're one of the more knowledgeable patients that have had a family member on it.
I'll try to summarize. So my son is 13 now, and when he was 8, he was diagnosed with craniopharyngioma, and he had a very large tumor, 5 centimeters, and it was taken out with a full resection. And after the surgery, he had hypothalamic damage, as evidenced by his hyperphagia, and he also had just temperature dysregulation, and So we were pretty sure he had that, and he also is pan-hypo-pit. So after struggling for a number of years with the hyperphagia in particular, I started doing some research, reading some articles, getting connected with people in the Prader-Willi community, and learned about oxytocin. So just found out that you prescribed it, tried it, and we first got, I think, 10-unit sublingual pills. Are you still there?
And how was that? How was that?
Well, here's the thing. We tried that for, we purposely didn't tell his teachers at school that we were trying him on a new drug because we wanted to get unbiased reports or blinded reports. So after about a month of his being on 10, and then did you go to 20 at some point? He was taking sometimes somewhere between 10 and 20 a day. So I think the prescription actually said like 2 pills a day or something like that. So anyway, after about a month of doing that, it was maybe the second to last day of school, and you know, we hadn't said anything to his teachers. So one of his teachers pulled me aside, unsolicited. I didn't ask her for feedback, and she told me that his behavior had been worse around food seeking and more defiant, like more aggressive and, you know, argumentative and all this. And, you know, I didn't know what to attribute it to, but I asked her how long she'd noticed it. She said about 1 month. And that's about how long he'd been taking the oxytocin, the 10 to 20 milligrams, or sorry, units. Then we got another report from another teacher with whom he has an excellent relationship. This is his orientation and mobility teacher, his visual impairment from the brain tumor as well. This teacher raves about him all the time, loves working with him. He's one of the most enthusiastic visually impaired students she has. And she wrote us an email, unsolicited, saying, you know, it was a good year with Sasha, but she's noticed in the last few weeks he has been more defiant and more intense about his food seeking. Even tried to manipulate her into going into a store to buy him some snacks or something, which he'd never done before. So I took this to heart and decided that maybe, you know, either the sublinguals weren't working or his dose was wrong. And, you know, I'm totally aware that there are no studies on this, so we don't really know what to do with dosing. So I think we contacted your office at this point and asked to be placed on the spray, because I have been in contact with 2 scientists who study oxytocin. One of them is a doctor, endocrinologist in Florida who studies the Prader-Willi folks, and the other one is a neuroscientist at Stanford who studies autism. And both of them thought that the sublinguals were not absorbed as well. So anyway, we went on the spray, and what did we do? Did we go on that for, I'm here with my husband. Did we go on that for about a week? Are you remembering?
Yeah.
Okay. So I guess we did the spray, and I think at this point we got 6-unit sprays. So we were doing 1 spray a day, and I think we may have gone up to 2 sprays a day. But we continue to see the aggressive food seeking, and, you know, mind you, that's the symptom we're trying to treat, so we certainly didn't want to see it get worse. So it seemed to be either no better or worse. So then I ran across a webinar that was given by Jennifer Miller, who is the endo in Florida, who studies the Prader-Willi kids, and it happened to be this brief little mention of another endocrinologist in France called Dr. Taubert, and she, in this slideshow, she reported that these 4 cases, it was just super anecdotal, these 4 cases of PWS kids were getting their doses that were between, there were sprays between something like 4 and 16-unit sprays, but they were only getting it once every 3 days. So I thought, I don't have anything to lose by trying to decrease the frequency of the dose, and we did that, and it seemed to work for a while. seemed to decrease his food seeking, and he wasn't finishing all his food. He didn't seem as intense about it, and it seems like it was going well. But we've had a lot of confounding issues with the experiment, which are very complicated. That some of them have to do with the other hormones being out of whack, namely the thyroid hormones we discovered at one point were super low. And we know that was, oh, I know what it was. He was starting to gain weight. That's what it was. He was having a decreased appetite and gaining weight, which didn't make any sense. So we checked his other hormones and found his thyroid to be very low. So we raised it. And at some point, we also discovered he was sneaking out of the house very early in the morning and buying tons of chocolate, like Halloween bags full of chocolate. So this was going to be a very large confounding factor, extremely the opposite of what we wanted. So that confounded things. And then, of course, the biggest, the most complicated piece has to do with the fact that we really, he's not reliable. We can't trust him to tell us the truth about how his appetite is or how he's, he's taking in food, because it's to his, in his hypothalamically damaged mind, it's to his benefit to get as much food as possible. So there's probably a lot more to tell, but I'll stop there.
So overall, did you think the lower dose of oxytocin actually helped him?
Oh, well, so today, now currently we're giving him 6 units per day. So we went to we were doing that every 3 days. Then we started to see that wear off. And so we thought, okay, we have to change something. We were on the every 3-day dose for about 2 months. And then we thought, okay, we'll try something different. So we went to daily. And then we started to see improvements again.
Right.
However, nothing's perfect. He was improving and still having some episodes of food seeking. But one of the things that I understand is that he's been, for 5 years, he's been controlled by the food police. That would be us. Because everything in the house is locked up. He has no access to food, no legitimate access to food. He has an aide at school who watches him unblinkingly, and, he's controlled. So it's completely normal and natural for a 13-year-old kid to want to say, to hell with you, I'm going to go get what I want. And so, opportunistically, he will go and get food when he can. So I'm just saying that psychologically, it's hard to account for whether he's actually still hungry, whether he isn't hungry, but he wants to take the food because he might be hungry later because for 5 years he's been deprived of food and he feels like there's scarcity, or, we just don't know.
But I think we can say that his appetite, more often than it used to be, his appetite is not as extreme. So he'll leave on the plate, which he rarely did before.
Right.
Yeah, he would practically lick his plate clean before. So, yeah,
and how about like emotional issues? Is he seem more calm or stable, or you don't notice any difference in that?
For the most part, he is, his premorbid personality, he's been a very affable, very sweet, lovely person. He's not prone to depression. He doesn't have any of those emotional issues like that. The only thing that sets him off is if we get into a fight about food. That will definitely set him off. He'll get extremely upset. And I would say to this day, that is still the thing that makes him most upset, because it's been the bane of his existence for 5 years. So I can't really comment on whether, in other ways he's calm and he always has been. So it's the food issues that still set him off.
Okay. So, thank you for sharing your son's experience. I think it sounds hopeful, but I think we need some tweaking in terms of what's the optimal dose. We might want to go up a little bit more. It does seem like you think that the intranasal is better than the sublingual, though.
Well, I really can't comment on it because the dosing is so questionable. How do I know it isn't dosing? How do I know what the problem is? Is he getting too much? Is he getting too little? Is it the sublinguals that made it not effective? It's too hard to say. we don't have any other, studies to give us references. And
But there was, well, I should ask you, there were some studies about sort of more aggressive behavior on higher doses. Is that right? Have you heard of those?
well, Dr. Miller has cited some studies where, or her own studies actually, where when some of the kids were given too high doses, and I think this is true in the autism studies as well, that it actually brought out more aggression, more tantrums. And the theory was that it was binding to vasopressin receptors. So I don't know how much veracity there is with that, but that was one theory that.
Right. I think it could bind to vasopressin receptors. The structure is pretty similar.
If it's too high or just at all?
I think at all, but at higher doses, it's going to have more crossover.
And if it did bind to vasopressin receptors, would that explain more aggression?
I don't think so. We talked about the effects of vasopressin. I think the main one, it would be more the water retention effects and not less urination. You could raise your ACTH up a little bit and your cortisol up a little bit. I don't see that as aggression particularly.
Well, here's the other thing. Now that you're bringing up the AVP, I have never met anyone in all of my years of reading about people with his brain tumor who have taken as high of a dose of DDAVP as he.
And right, he's on a very high dose.
Yeah, so he takes 20.2 milligram pills per day, and if he doesn't take that, he has chronically high sodium. So I'm just wondering, what does that mean? Like, why does he have to take such a high dose? Does it mean anything about the extent of his brain damage, or you know what I mean? Why do some people can only take one pill a day?
Right. I think that's a big question, and I think it shows, first of all, he probably has fairly complete vasopressin deficiency. He doesn't have partial. He's not in any of it. And then I think it has to do with two things. I think it has to do with his vasopressin is probably being broken down more. There's enzymes that break down vasopressin that vary among people. So I think he's probably breaking it down more, and possibly something that is a receptor that he's not, he's not getting a full effect of the receptor. I would say, at least what we know now in 2016, he needs to take whatever he can to normalize the sodium. Even if it's 20 pills a day, I think that's what he needs to take. He doesn't have any signs of overdose. And you would think maybe it's going to be the other way around. Maybe the vasopressin is going to bind to the oxytocin receptor, and he might get some benefit from all those vasopressin binding to the oxytocin receptor and would have less appetite and wouldn't need the oxytocin, but that doesn't seem to be the case.
No, I mean, he now that we're taking it every day, we do notice that it's helping him urinate less. So just in the last couple of days, he peed twice. Like, he's taking his 20 pills a day, and he's getting his one spray of oxytocin, and he's peeing twice a day, which is actually fine with me because he's got super high sodium.
Right.
So yeah. So and then the other thing we were going after with the oxytocin deficiency treatment is that he seems to have this very strange aloofness towards his peers. He is, even though he's an extremely affable person. I mean, people who know him, like adults, love him. He's very charming. He's very friendly. Sociable. But he has no friends. He doesn't have any friends. And this is odd. It's odd for a very sweet, lovely, friendly person to have no friends. And I don't know how else to explain it except there's something going on perhaps with the oxytocin deficiency. So let me ask, I want to ask Mr. Howard if I don't see his microphone on, but maybe he can turn it on or give us a chat response. So Mr. Howard's been on as hypopituitarism, adult hypopituitarism. He's around 50, and he started taking oxytocin maybe about 3 months ago. And he said people are just walking up to him, starting talking to him like he's so much more outgoing and sociable, and people are saying he's smiling more. He doesn't, it's more the reaction to his colleagues about his friends. He says he's never been so well liked since he's been on this oxytocin, which I think is an amazing change. Tom, can you turn on your microphone and comment, or respond on the chat on this?
So let's open it up to the chat. Maybe Tom can come back. So in general, use the chat button. Please relate your questions to this topic. Share your experience with us. One person until everybody until everybody asks a question, one per question. Try to keep them general if you can and not that personal. So here's Thomas' response. He said yes, include strangers are coming up to him. I think it's quite interesting how the oxytocin, just a fairly short period of time, has made him more helpful. So Tom, if you want to just do the chat, I think people can see the chat response here as well. We'll go to Sharon's comment first. She gets her oxytocin 20 units sublingual from oxytocin university compounding. And Sharon, if you want to respond how you like it and how you like the sublingual. Pat asked the question, I'm having trouble with diabetes insipidus in the PM. Morning osmolality is okay. Is this cyclical pattern common? You know, I think your effect of the vasopressin can vary throughout the day. Most people, as I said, I like to give it at night because I don't want people to wake up at night. But in Pat's case, she could take some vasopressin in the late afternoon, just as long as she has some breakthrough urination, and that could stop her diabetes insipidus at night. I think she has to sort of be fairly flexible and see how it goes and how it affects her. Okay, other questions on the chat here? Tajana, does the oxytocin not work as well in adult females since the studies were all for men? That's a great question also. I don't know why the studies were in men and not females. I think in general, often people study males maybe inappropriately because they don't have to worry about estrogen cycles. So if there's some concern that this is affected by estrogen cycles, you may get variability depending on the cycles. But I don't really know that question. I'm not sure it doesn't work as well. My guess is I think it works more, is my experience. I think just they were more convenient to do the studies in men. Okay. Lisa is asking, if someone has adrenal insufficiency, not known yet of primary or secondary, does the low cortisol levels imply that wouldn't be oxytocin deficiency? Not necessarily. I mean, I think these are separate axes. You could have cortisol deficiency and not oxytocin deficiency, certainly more common and expected. You could have oxytocin deficiency if you have more of a posterior pituitary defect and not have oxytocin and not have cortisol defects. Or you could have both, or you could have neither. The cortisol is one of the hormones that's the most preserved. You have to have fairly high damage of your pituitary to have a cortisol defect. So I would say you're more likely, if you do have a cortisol defect, also have an oxytocin defect. Pat asks, I have tried oxytocin and did not notice changes. What is the half-life of the spray? Does it need to be used for extended periods? Would it be advisable to try the tablets instead of the spray? So those are great questions also. I think it lasts several hours, and we often give it 3 times a day, although as we heard from Eugenie that, she gave it to her son first every 3 days and every day. And then I think if the spray doesn't work and you're at a reasonable dose, something like 20 units 3 times a day or so, you could try the tablets. The other thing is to get tested with the urine test to make sure you're deficient. Again, I don't think the urine test is perfect, but I think it will give an idea. Janet says she's taking 40 units twice a day sublingually from the University Compounding Pharmacy. I'm also more outgoing. It seems like the oxytocin is decreasing my AVP effectiveness. Does that make sense? I would say yes, as Eugenie said also, that the oxytocin can bind to the ADH receptor. I think there is some crossover with the receptor, and it can somewhat replace the AVP and maybe at a lower cost. So I think it can very likely decrease your DAVP levels. Eugenie asks, would testosterone replacement enhance the effects of oxytocin? I haven't seen any literature on that. I do think people should be fully replaced, and we talked to Eugenie about putting her son on testosterone. I think it would be reasonable, but I don't know if it's going to specifically affect oxytocin, but it'll be certainly important to look at. Kelly said, I was told that it was more because of my body language and facial expressions that presumably the oxytocin helped her. She prefers the nasal spray so much more, but, and it's important, but it doesn't spray consistently. So that seems to be a common feeling, is that the nasal spray works better, but it's inconsistent. I have some issues that make it so I don't get a consistent dose. I thought it was from surgeon, but it looks like an allergy or autoimmune disease. I hope to get back. To go back on once this is addressed, I was using sublingual, but it's not as convenient, it doesn't work as much. However, coming off, I noticed it did help. My brother was married in the early summer, and I spent most of the reception dancing with my niece and nephews. They are 2 and 4, so it was a lot of carrying. I struggled, but I was really driven to participate. So it looks like Kelly had a pretty good effect on it. We're still trying to figure out the sublingual versus the nasal. Sharon asked, I like the sublingual tablets I received from University Compounding. It is the only pharmacy in type that I have tried. The sublingual tablets are small, round, half disc, have a pleasant mint flavor, and dissolve rather quickly. That's great. Kelly says, oops, I got mine from Longs, but I'm not a fan of them. I used to get a 3-month supply, but I think it's less effective over time, so I'll be doing 1 month at a time. That's interesting also that, we don't know how long these last and should they be refrigerated or not. So that's a good point from Kelly. Sharon asked, if somebody has, I think that's subclinical adrenal insufficiency or subacute adrenal insufficiency and takes oxytocin, what increase of hydrocortisone would you recommend when taking? So, it sometimes maybe go up by 2.5 milligrams. I would say that, you need to base it on symptoms. Where is my mouse?
Other question?
There it goes. Feeling more fatigue since starting oxytocin, but have not increased, didn't know it was necessary. Yeah, I would probably add an extra 2.5 milligrams of hydrocortisone and see if that helps you. Christine asked, when your patients with low cortisol start oxytocin, do they have to increase steroid dose change? I don't know if they have to, but that seems to be a fairly common finding that they need more. So I would say it's fairly, if they get signs of adrenal insufficiency, which would be nauseousness, vomiting, abdominal pain, diarrhea, weakness, low blood pressure, nauseousness, any of those symptoms, I would quickly add more cortisol. Eugenie asked, concerning diabetes insipidus, electrolyte testing, we have to get weekly sodium tests to make sure he's sufficiently hydrated. Yes, no, first. Why is sodium the only mineral that is tested? Are the other electrolytes ever important to test? And I would say no, really sodium is the key thing. It does regulate your free water that's reflected on your sodium. The sodium is really the key thing that's affected by the DDAVP and really is the crucial one to monitor. If your sodium is too high, you need more. If your sodium is too low, you need less. There's chloride sort of reflects sodium because you have sodium chloride, but the sodium is the most specific and the best thing to monitor. Okay. Okay. Vogue asks, I tried both the sublingual and the nasal spray of oxytocin. The nasal spray worked a lot better. I noticed the spray worked better when Bellevue made it, but now I can get it from Walgreens, and it doesn't seem to work as well. It's helped with anxiety, it made me more sociable, helped me handle stress better, and I think clearer. I feel like my old self before I had pituitary problems. So that's quite good from Melissa here in Grand Junction, so that's great. Unfortunately, as you guys know, Bellevue was a great compounding pharmacy that went out of business, so we're sort of struggling to find a good one to replace it. Lisa asks regarding AVP-DI, is it possible for the pituitary to sputter and it's functioning so that one would have symptoms of DI for a few days at a time, urinating hourly but no increased thirst, and then back to normal. Is this more related to AI symptoms and treatment? Yes. So adrenal insufficiency can mask diabetes insipidus, and when you treat it, sometimes the diabetes insipidus gets worse. Patients with central adrenal insufficiency have SIADH and have low sodium. So it's usually not diabetes insipidus, and I think you can have sort of mild cases, in some episodic cases, where you have some days it's okay and some days it gets worse. I don't think this is well studied, but that's certainly been my experiences that it can come and go. Eugenia asks, what are the other clinical reasons people have oxytocin replaced? Are there others who have hypothalamic obesity or are taking oxytocin currently in this group? I think most people have this hypopituitarism. Most of the people that I think are on it, that I've given it to, have either prior surgery, radiation, some type of damage to their pituitary, and that's why they're taking it. I think it's very hard to diagnose hypothalamic obesity. I think some of our patients have that also. They might have had craniopharyngiomas as a child and had surgery. Some of them might have gotten radiation, and I think some of these may benefit from oxytocin. People can respond to the chat about what their underlying condition is. Pat is saying, I got the last prescription of oxytocin spray filled at San Diego Compounding Pharmacy. They informed me that the prescription should be kept refrigerated all the time. So that sounds good. I think everybody is probably, that's a reasonable choice to keep it refrigerated. Liz asks, is anybody who is pan-hypopit and experiences stress and anxiety a good candidate for taking oxytocin, especially if the other approaches don't seem to help? I think yes, I would definitely do that. From Liz, get tested and get on it. You probably might be the key thing. Janet's saying, I found that oxytocin reduces my potassium and magnesium. I started getting terrible muscle cramps, spasm, replacing both eliminated the problems. So again, there seems to be other effects of oxytocin on electrolytes that some people get. You just got to watch out for it, and replacing magnesium and potassium is what I often do for patients with cramps, so that seems like it's a good choice that Janet came up with. Jason asked, I'm very interested to hear more from the male patient who has noticed a significant improvement in social interaction with the others that he noticed. I'm a pan-hypopit patient myself for the last 16 years, recently became disabled due to the condition. I have total apathy, total disconnect, antisocial depression. I've taken numerous psych meds and nothing seems to work. I think you're a great candidate, Jason, for oxytocin, and remind me to send you the information on testing it. I think you'd be a great candidate for it. Liz is asking, I have some rapid aging of appearance after starting oxytocin pills. Thinning of the skin on my neck and feet, why might that be? I don't know, that would be a good question. I would say in general, you would lower your cortisol. Your thin skin is usually due to high cortisol. You think you lower it, you might get better. I'm not really sure why. I think that's an interesting question. I don't have any great answers from it. But if it's not helping, that sounds like you might want to stop it. Sharon says, with diabetes insipidus, do you recommend electrolyte drinks to assist with electrolyte balance? Yeah, I think electrolyte drinks are okay. I think mostly it's the AVP and it's free water that you need to drink more water, but electrolytes help. Electrolytes are often more regulated by aldosterone, and the AVP regulates vasopressin more. Michelle asked, could a closed head injury or sudden stop of 4NF be the genesis for oxytocin deficiency? Yes, definitely a closed head injury can damage your posterior pituitary and hypothalamus. And a stop in 4NF, I would say that's less likely. The 4NF affects your aldosterone. Oxytocin, I don't think should be affected by that. Janet asked, University Compounding Pharmacy wants oxytocin refrigerated. They even charge extra for overnight ice shipping to ensure reliability. I think that's a great point. If diabetes insipidus is a possibility, then urine color goes from dilute to normal, but also still the same volume, is a good idea to test for diabetes insipidus. You know, usually the diabetes insipidus is a dilute urine that would be very clear looking. Is it better to go ahead and test for other issues like kidney and A1C? You know, it's possible. I doubt you have kidney problems or diabetes that's causing the problem. I think it'll be reasonable to get the diabetes insipidus issues. Janet says about charging extra for the shipping on ice. Eugenie asks about, I read today about one patient's use of choline as an adjunct treatment for oxytocin. Anything about adding choline to boost oxytocin's effect, decrease obsessive features, addiction, and muscle tics? That I don't know anything about that. Sorry. Okay, Howard's back in again. I'll chime in again. I've tried, this is interesting, I've tried a number of psych meds before figuring out my issues are endo and cardiac related. Only AD antidepressant that comes close to oxytocin feeling was an MAOI, but which has side effects and hypertensive crisis potential. So I think Howard is agreeing that seems like the oxytocin seems to help a lot with the social issues and depression issues that some of the psych meds didn't seem to address. Okay, we're coming up to 7. So anytime, maybe we'll take 2 more questions and then we'll call it a night. Lisa asked, does any of these affect heart rhythm? Could intermittent bradycardia and SVT events be caused by diabetes insipidus or oxytocin deficiency? I don't think so. I think that this, you know, the bradycardia could be hypothyroidism, but it's probably a cardiac event. The supraventricular tachycardia is going to be the other way around. That means rapid heart rate. That may be due to dehydration, more from an aldosterone deficiency than a diabetes insipidus deficiency. Pat asks, would the medicine for my diabetes help with low blood pressure? I have low aldosterone and take 4.5. It shouldn't help too much with low blood pressure. It usually affects more the free water clearance. The aldosterone and the 4.5, as Pat is taking, is more important for the blood pressure. And we'll close with Janet. She's read about low-dose naltrexone to help depression and brain function. Are you familiar with this? A lot of interest in low-dose naltrexone. It seems to help with several things, but not for everybody. It seems to help some people with some sleep and some memory issues. You know, I think you have to try it out. Jason asked, Dr. F, what do you recommend for dosing for my apathy antisocial? How to present this information to my endo other than your research? I think you're going to hard to find other endos that are into this, to be honest. I think you're going to be fairly stuck with using me. And I think it's worth a try for sure. How frequently do you test oxytocin if someone wants to switch back from another form? Should they get testing? You know, I haven't been pushing my patients to do enough testing. I think it would be good to see that it goes up after it. Maybe some people aren't responding because it hasn't gone up. And I think it's reasonable that if you've gone on one form and then you switch to another form, you get tested. Michelle says, Trinity Pharmacy in Carrollton, Texas, and Dougherty's Pharmacy in Dallas are both compounding pharmacies that might be able to fill oxytocin prescriptions if one is interested. Trinity does a lot of compounding for other pharmacies. Hope this helps. Okay, so I think it was a great seminar. Janet says the oxytocin test has been reduced to $130. Excellent. Thanks everybody for joining. I'm going to try to post this on my website in the next couple of days and keep me posted about it.